And Paul is nice enough to come down to Everett, which he does every week. But today he's going to talk with us about immunotherapy. It's something that all of us deal with on a daily basis, but we don't talk about it as much as we should. So, Paul?
Good morning. I wondered where the word suppression came from. I thought Drew made that up. He says that's not. He says that Skim makes that up. So we just go ahead. I don't have any disclosures, which is too bad. It'd be nice if I had some disclosures, but I don't have any. So the question I asked myself when I got this topic is, what would Leonard Noon do now? I mean, this is the guy who started the whole thing in 1911, and somehow out of the air, this guy pulls the idea that if we injected people with toxins from grass, that we're going to do something good for them. So I'm not sure exactly how he came up with this first thought, because nobody else had ever done that before. But he was right. And the problem is 103 years later, we still don't know exactly how immunotherapy works. It does work. It's been proven in multiple studies. But the mechanisms, as you will see pretty quickly, they haven't changed much since I looked at this about 15 years ago. So there's a lot more science, but it still goes in circles. So if you look at what happens with immunotherapy, I mean, there's still a bunch of different clinical events that occur that nobody knows really which is the most important. So you develop tolerance. It's manifest as a decrease in antigen-specific responsiveness accompanied by T-cell anergy and T-cell apoptosis. There's also generations of new clones of regulatory T-cells that are CD4, CD25 positive, and this occurs very early in the immunotherapy. And then these regulatory T-cells make IL-10 and TGF-beta, which results in a decrease in the B-cell specific antigen presentation and increasing in IgG4 levels and reduction in the pro-inflammatory cytokines. So this ends up with tolerance in the T-cells by means of inhibiting their CD28 co-stimulatory pathways. And fortunately, David and Matt are here, so if you want to know what that means, we could probably ask one of them what that actually means. But I didn't get much more into it than that. There's also a generation of allergen-specific IgA, which then induces IL-10 from monocytes. And the IgG and IgG4 levels increase with successful immunotherapy, and they have an increase in allergen-specific IgG4, but none of those are necessary for success of immunotherapy. So downregulation of IgE and increase in IgG4 specific both precede the actual effect of immunotherapy, but they're not necessary for immunotherapy to actually work. So even though we think that we have the mechanism understood, if you take away those two variables, immunotherapy still works, but it doesn't work through either of those processes, at least as an independent process. So there's a whole bunch more to this immunotherapy science that I think you should at least hear. Whether or not it makes any difference, I'm not sure, because it's still, I don't think anybody is convinced that they understand the complete mechanism. But what you see is, as you continue the immunotherapy course, you'll see an increase in the production of IL-12, which then results in allergen-specific deviation from a Th2 to a Th1 cytokine profile. And there's an initial increase in antigen-specific IgE, followed by a gradual decrease towards baseline or even below. And this clinical improvement occurs before the measured decreases in IgE levels. So the patients are responding, and yet the laboratory studies are lagging behind. So IgE decrease is not necessary for allergy shots to work. And there's a release of vasoactive mediators from basophils and mast cells that you can block with this selective IgE. But again, this is not necessary for immunotherapy to be successful, that you find this specific IgG4 or downregulation of IgE. So IgA and IgG levels have also been associated with immunotherapy, and it sort of made me cringe when I thought of food allergies with IgG4 and IgA coming back to haunt us one more time, that maybe there's another mechanism that we've not seen. And IL-10 seems to be one of the key mediators here. That's when it's released from monocytes, you further knock out this B-cell function and decrease in specific IgG4. And then these IgG molecules, the G4 and the IgA, just keep being generated, and they correlate specifically with the allergens that you're injecting, but they don't correlate with the response. So no matter how I looked at this, I can't convince myself that increase in IgG4 or decrease in IgE, which is what I've always thought is the mechanism, that's not really the mechanism. There's something else involved that has not quite been worked out. So you can see that this change in IgG specificity, the actual binding of the antibody occurs before the IgG titers increase. And most of the research now is focusing on the fact that immunotherapy changes the specific binding capacity of the IgG molecule more than it makes the IgG quantitatively higher in an IgG4 setting. And this allergen-specific IgG can block IgE-dependent histamine release, and it can also block presentation of IgE antigen presentation assistance to T cells, but neither of these, again, is effective at predicting whether your immunotherapy course is going to go good or go bad. So they're all sort of epiphenomenons that you can show downregulation of IgE, you can show specific IgG4 and IgA, but it seems to be a conformation change in the specificity of the IgG molecule itself as opposed to the quantitative changes that we measured. So you have just a couple more of these slides to confuse you completely before we move on, is that you can show proliferation of peripheral blood mononuclear cells through the actions of IL-10 and TGF-beta, and then you suppress lymphocyte proliferation by decreasing IFN gamma, IL-5, and IL-13, which suppresses both Th1 and Th2 cells. And then over time, that suppression sort of drops out, and IL-12 seems to be the main mediator at the end of this transition from Th2 to Th1. But again, there's an early response consistent with regulation of T cells that suppress both Th1 and Th2, and then eventually the response shifts to just basically more of a Th1 response at the end. So, when do you use allergy shots? And this is the question that we get to ask all the time. It's effective for the management of allergic asthma, allergic rhinitis conjunctivitis, stinging insect hypersensitivity, and actually new data suggests that we should use it for atopic dermatitis when they're sensitized to dust mites or pets or something there. So they recommend still that we do skin tests instead of blood tests because it correlates better with response. And it really should be brought into the equation fairly early, but mostly in people that can't get reduction in symptoms with pharmacotherapy, and they just won't take medicines or can't take medicines, which is where the actual recommendation is the strongest. So when you decide you're going to use it, this is where we are getting into our medical legal issues. And one of the things I didn't realize about the administration of immunotherapy is we're supposed to be present and we're responsible for everything that goes on, but yet we don't have to actually be directly supervising immunotherapy, which sort of is a twisted in the direction that we were given before. So you have to tell these people that, this is a possibility that this is going to work. You need to go through the risks and benefits, and we now have since the Everett Clinic is now on the national radar, we have a very robust department in quality, and we have to co-sign everything and consent people for everything. So what used to be the nurses consented people for immunotherapy, now we have to do that. We have to make them sign, and all these horrible reactions that can occur, and people still sign it, so it's obviously not enough to discourage everyone. But you want to do your immunotherapy in a setting that permits prompt recognition of adverse reactions. And I don't know about your staffs, but I'm sure my staff see more anaphylaxis in the emergency room because we seem to cause it all the time doing our immunotherapy. And a lot of the patients still come in, can I give it at home? Can my neighbor give it to me? And I just say, I can't do that. And before, we would be a little bit more lenient, but now I'm finding that we're becoming less and less interested in anybody doing shots anywhere other than in a physician's office. And I have one paramedic who says, can his buddies and the paramedics give him his shots? And that's when I've not wrestled with a solution yet, because it probably is the safest place for him to get a shot because he's got all his buddies there. But it's just, it's become a medical legal nightmare, as our risk management department tells me, as they change our consent form all the time. So you can have local and systemic reactions. The most serious reactions develop within 30 minutes. And this has been a topic of discussion for the last probably 10 or 15 years, is how long should we make patients wait? And although these systemic reactions can occur after 30 minutes, it really seems to be that the bulk of the really dangerous ones happen much faster, and the delayed systemic reactions can occur, but they don't seem to be as severe. If you look at the more recent studies, initially it was thought they could be just as severe as well. So there's been multiple studies done regarding the safety of immunotherapy, and there's a study in 2008 that recorded a total of 48 fatalities from immunotherapy, and they calculated that that's one death per 2.5 million allergy shots. And they had no fatalities in the year of 2008, and they gave 8.1 million injections. I'm not sure exactly how those numbers were achieved, but they seem very confident in their numbers. And then if you look back over the big study that was done in the 1990s and early 2000s about fatalities, poor asthma control seems to be the major risk factor in all of the safety studies. The issue of beta blockers has sort of come and gone, and now with our cardio-selective beta blockers, the advice is it may increase the severity and treatment resistance in aeroallergen immunotherapy, but it doesn't seem to hold up in venom immunotherapy, which didn't make sense to me. And then ACE inhibitors seem to increase your risk in venom immunotherapy, but they don't seem to increase the risk with aeroallergen immunotherapy. So I'm not sure that the answer about beta blockers and ACE inhibitors is in yet at this point in time, because there's still some conflicting data there. This late allergy reaction data, if you look at the multiple studies that have been done and you summarize them all together, which is what they did in the practice parameters, the third edition, 78% of all fatal reactions and 96% of all non-fatal reactions occur less than 30 minutes from immunotherapy. So our 30-minute wait time is going to pick up most of them. In the biggest study that was done, up to 50% of all systemic reactions, which were not fatal systemic reactions, happened after 30 minutes. But in the same study, all of the ones that happened after 30 minutes were considerably less severe than the ones that happened in the first 30 minutes. So there seems to be the trend that goes through is that the dangerous ones happen earlier. You can have reactions later, but the later reactions don't seem to be as life-threatening as quickly. And no matter which study you look at, poorly controlled asthma continues to be the single biggest risk factor for all of the side effects of immunotherapy that we see. Now, there's a study that I read that I was just fascinated by about 15 years ago that says we're not putting anybody at any increased risk with immunotherapy building up during the pollen season. And inherently that makes no sense to me, but they've done 3 studies now that all show the same thing. And there's no evidence-based data to support dose adjustments for missed shots during the buildup. Although when they polled the allergists, 90% of us say we reduce doses as soon as people miss shots, but there's actually no evidence-based data to support that. Cluster immunotherapy, I don't know if any of you engage in that. We found out from our insurance carriers that they won't pay for more than 1 allergy shot per day. So the idea of giving them 2 to 3 shots in a day is interesting, but we won't get reimbursed for it. So I guess that may be the reason that we don't do it around here. I don't know. But rush immunotherapy has significantly more reactions than the other schedules, except for venom. It looks like you can go right up with venom really fast and not get into much trouble, whereas the cluster immunotherapy, the normal mainstream immunotherapy, there seem to be about the same in terms of reactions for those 2 approaches. The next piece of the safety data we got into in a sort of a very fervent discussion at the Everett Clinic, and using these small needle syringes that we've been using forever. And our clinic wanted us to switch everybody over to the safety needles. So we did our own study there, and we found out that the needle sticks happened to the nurses much more frequently with the safety needles than they ever did before with the little TB needles that we use and the allergy shot needles. So we've gotten an exemption from our clinic to quit using the safety uncappable needles. And then the second question was, what happens when you aspirate? Do you get blood? What do you do with that? Well, half of the allergists polled said they don't even think that we should aspirate for blood because the needles are so small you're not going to get anything that big anyway. And then if you do aspirate and get blood, they recommend that you throw out the whole syringe and start again and don't use that syringe at all. So I think those are 2 more things that are sort of open to discussion, whether we should actually even require aspiration of the needles or whether we should just ignore that. But it sounds like going to the safety needles has not been a great panacea for the nurses giving injections or anyone else. It seems like that's not been proven to be safer. Pre-medication with immunotherapy, I know this was controversial when I first learned about this, and if you pre-medicate, it does decrease the frequency of systemic reactions and increases the number of patients who get to maintenance. And this is from the Practice Parameters 3rd edition, and there's 3 or 4 other articles that support that. It also decreases the number of large late reactions, and more patients in that group are able to reach the target dose. So we can discuss whether we all do it or whether we don't do it, but the statistics would show that it does help your patients get to full dose, and it does keep them from having bad reactions. Epinephrine is still the drug of choice for systemic reactions, 0.2 to 0.5 milliliters every 5 minutes as needed during a bad reaction. In kids, it's 0.01 milligram per kilogram. And there's a couple of studies that show that if you inject epinephrine into the thigh instead of the opposite arm, you get much more predictable response and much higher blood levels than if you go in the opposite arm. So I think our nurses still give half of it in the shot site and the other half in the opposite arm. And we may have to rethink that because it doesn't look like that is necessarily the safest way to do it. And then so far the studies, show that giving Xolair with immunotherapy, there's not enough data to give an answer one way or another yet, whether that's a good idea or a bad idea. It's a novel idea, but there's not enough data to support that one way or the other. Now, immunotherapy orders. And I don't know about the rest of you, but my training in immunotherapy with Mike Kellner was about 1 hour. And then just a bunch of discussions after that, but we really didn't.
Excuse me, before you go into that, the fatality rate of 48 deaths from IT, is that worldwide? I thought
it was in the United States over about 27 years. So it wasn't many, but almost all the deaths were from patients that were getting their shots outside of a medical institution.
But it was that high, huh?
It was that same study that's been discussed in about 4 other papers since. So they only had the one study that got the 41, and then they added 7 more as they kept reviewing that study. 70+% of those people were out of control asthmatics that were getting shots, and about 60% of the deaths were not in medical institutions. They were people getting their shots at home or by a friend. And the data is really not supportive of ever doing it outside of a doctor's office. That's for sure.
Paul, in that same vein, did they talk about that? It looked like there was a 22% chance that it was after half an hour, like people leaving the clinic. I mean, just based on that alone, granted, if you do the math, it's about 1 in 13 million shots. So the odds of you individually ever getting anywhere near that are low. But it's a little unsettling.
It's always bad when you're that one, though. That's
exactly.
I always look at these statistics, and then I see a patient who has the disease and go, boy, you really have bad luck. You're the 1 in 10 million. But it's an interesting thought because the studies that look at the late reactions say that they're not as bad as the early ones, but yet some of the deaths happened after half an hour. Again, the highest risk group of these people are people that are not in physicians' offices and people that have asthma that's out of control. So, and if you look at the data on deaths, almost all the patients are asthmatics, and again, 2/3 of them weren't in a doctor's office. So I think we need to take that message to heart, and when the patients say, can my family practice doctor give it in Ketchikan, you may say, I don't know, do you really want to trust them, and see what they say. So it becomes a personal issue.
Paul, was there any comment? I understand the blood level thing with giving the shot in the leg, but about giving the shot into the large local reaction with epinephrine?
Actually, they sort of glanced right over that in the paper. They talked about giving shots in the shot site and then in the other arm.
Oh, I see.
And they said that gives unreproducible epinephrine levels. So they recommend giving it in the ipsilateral or contralateral thigh. But, I'm not sure that, I think most of that was EpiPen data, because I don't think many doctors' offices are going to make people pull their pants off to give them a shot of epinephrine. So I suspect that was all EpiPen data, because I know a lot of it was. But it was just an interesting thought, because I figured if we get them early, they're still perfusing, but obviously perfusion of the thigh is going to go on later than perfusion of the arm. So, anybody else have any experience with that? Have you guys used allergy shots in the thigh with epinephrine? Has anybody done that? See, one of our 4 doctors, Jen Lee, she likes to give it in the thigh. And that's what they did at Scripps, I guess, because that's what she likes to do. But it would take so long to get their clothes and everything out of the way. And unless we stick through the clothing, I don't think that's really going to help much. Yeah. So if you look at the allergy extracts, we have them in different forms. There's aqueous, glycerinated, lyophilized, acetone precipitated, and alum precipitated. And each of them has some good parts and bad parts to them, but most of it is stability issues more than anything else. Glycerinated stock, by definition, is 50% glycerin. And the other liquid-based extracts can either be saline-based, buffer-based, or liquid diluent. They're all referred to as aqueous. The lyophilized extracts, mostly we see that in the bee venom more than anything else. They're considered lyophilized, but as soon as you reconstitute them, then they become aqueous extracts at that point. The alum precipitated goes through this extra processing step where they add alum, or which is aluminum hydroxide, and then they get sort of a time release of that allergen in the skin, and there's not a lot of new data on that. That's, I think, I don't think they've changed that technique in a while. And then the acetone precipitated extracts, this is an extra processing step where they take the protein out of solution with acetone, and this is where Hollister Sear has gotten their super dog extract, is with the acetone precipitation step. Now, standardization is sort of an unpleasant reality. There's only a few standardized allergens now, and if you look at what's happening in the industry, we may not get very many more standardized allergens in the future, because the hope was we'd standardize everything, but reality is there may not be any more standardized extracts in the near future. And they're standardized based on intradermal skin testing for the Center for Biologic Evaluation and Research, and they inject these extracts into people, and they get a measurement of perpendicular long axes of 50 millimeters, and then those become the standards for which the other allergens are compared. And then these reference standards, the manufacturers can get them to make sure their lots fall within specified ranges. And more importantly, now that we have the standards that they can set up with repeated skin testing, they can figure out what protein content actually correlates with those variables. So hopefully in the future we won't be standardizing things based on skin test data. We'll actually have quantitative data on the allergen. So the standardized ones we have are cat hair, dust mites, short ragweed, grasses, basically all the grasses, Hymenoptera, and there was hope again to standardize things, but there's nothing near standardization now. I don't know, Sean may know about the dog extract from Hollister, whether that's going to ever get standardized, but it's finally on the market, which is more important to whether it gets standardized. The guy you referred me to wasn't sure what the status was on standardization. So
standardization on most extracts is still pretty far off.
Okay. So
most other extracts than what you've got listed.
Okay. So now 797, I don't know if any of you know what caused this uproar about 10 years ago, but USP 797 was adopted listing rules and regulations for compounding sterile products, which basically, had it been enforced in its initial form, we would have all been not giving allergy shots anymore at all, because they would have eliminated our ability to do the extracts and use them the way we do, because the law states that any compounded sterile product, after it's been opened, has to be disposed of in 30 days. So that all of our stock bottles of allergy shots would all be disposed of in 30 days. And so there's enough of a controversy that the Academy went back and worked with the USP, and they had a second meeting in 2008, which basically came out with a dedicated section just for allergy immunotherapy. And they realized that the extracts and vaccines that we're using are quite different, and they really didn't fit in with the heart of the law was to protect people from using stuff that just sits in a closet all the time and people draw from it once in a while. And they realized that that's not what we were doing. So they gave the allergists, meaning us, an exemption if we meet certain criteria. The criteria are that the compounding process involves simple transfer of sterile allergens, that all extracts contain appropriate substances to prevent growth, which is either glycerin or phenol. Before beginning compounding, personnel have to have a thorough hand washing procedure. Then they have to cover their hair, cover their face with gowns and masks. And then they have antiseptic hand cleansing with alcohol based with surgical hand scrubs. And they do that intermittently the whole time they're compounding. The gloves they use have to be compatible with 70% alcohol. And then the vial stoppers need to be wet and let sit wet for 10 seconds with the alcohol and allowed to dry before they can be used. And that all these things are meant to minimize direct contamination of the critical sites, specifically needles, vials, and stoppers. And that the label on each multiple dose vial gives the name of the patient, the expiration date, the storage temperature. So everything got a lot more complicated. Now, I don't know if all of you have nurses that do your mixing, but legally we are responsible for everything that they do, and they're not responsible for anything. So if you have a nurse that wants to get you in trouble, there's a real easy way for them to do that to us, which is we are solely responsible for everything we mix. It doesn't matter who mixes it in your staff. They carry no legal responsibility, which didn't make me feel all that much better. But that's the way that sits. So we're supposed to supervise the allergy immunotherapy training, and we're supposed to basically make sure that we think the compounding personnel are using aseptic technique and that we train them. I'm not sure a lot of doctors would pass aseptic technique at 10 or 15 years after medical school, so I'm not sure we might not be the best people to teach them. But the idea of wearing gowns and wearing gloves, I'm not sure if your nurses do that when they do your compounding. I know our nurses wear masks and hats, but they don't wear gowns, and they use gloves. But we have one dedicated area that we do, but that, again, has to be cleaned very specifically. And if you're inspected and you don't meet these requirements, then I don't know what kind of recourse you have if you get in trouble. And then all the extracts have to be bacteriostatic, which means they either have to have 0.25% phenol or at least 20% glycerin. And then they all have to be diluted in accordance with the manufacturer's instructions, which means you have some aqueous extract, some acetone precipitated, some glycerinated, and you mix them all together. So the end mixture is a combination of your extracts plus 4 or 5 different chemicals.
You know, in all the years I've been doing this, I've never heard of anybody injecting and having infections at the site. Does that occur? Does anybody have problems like that?
I've not seen infection. We've had a couple of people with local nerve injuries where they say that their arm's been numb or sore for a while after the shot. But they've looked back on allergy extracts, and I don't know what we're doing right, but they've never found an infected extract for the last 30 years, and every time they've looked. So they'll just randomly screen a bunch of patient extracts at different institutions, and they culture them, and they've never been able to show that we've ever had any infection. So,
Has Hollister Steer ever had problems with it? Infected extracts?
No.
Because they'd be probably the biggest risk. No, I've never heard of it, so all of this may be moot.
Hopefully. But there hasn't been an infected extract detected in a long time, and they keep trying. Now, the next thing is when you're compounding, what do you mix and what do you not mix together? I mean, we all know the alternaria and grass story, but there's highly proteolytic enzyme-containing extracts, and there's low proteolytic enzymes. So the high proteolysis stuff is mostly whole-body insects and fungal extracts, and they're considered to all be high levels of proteolytic activity. And the proteolysis can actually break down the structure of the allergen itself. And I just remember hearing about the alternaria and grass, and at the end of a month, there's basically no grass pollen left in the alternaria bottle. So they recommend that we mix things accordingly. So based on the concerns that have been addressed, fungal and insect extracts, you want to keep them separate from all your other allergens. And pollen and mites and animals don't seem to have much proteolytic activity, so they can all be mixed together. Now, most of the stability data is done with low protease extracts, but the stability data is not really very good there. And then if you look at diluents, glycerin is the best way to store things. 50% glycerin, the extracts stay good forever. They don't change at all. The only problem is 50% glycerin is incredibly irritating to the patients. So if you look at the proteolytic ones that we use, Alternaria, Aspergillus, Penicillium, Bipolaris, Cladosporium, German cockroach, American cockroach, and fire ant. These are all non-standardized, and they're all in 1 to 20 weight to volume extracts, and I think you can get 1 to 10, but they're all in glycerin, because if they're not in glycerin, then they destroy themselves. So the reason that we get them in glycerin is because that inactivates their ability to destroy themselves as well as everything else. So if you have storage and you put Alternaria in with anything else, Alternaria at 50% can stay stable for the entire year. But if you put Alternaria in at lower than 50% glycerin and you mix it with fire ant, then the Alternaria didn't survive at 10 and 25% glycerins, but at 50%, it was good for basically the whole year. And then there's a whole bunch of studies that I got from Greer that show stability of mixing allergens with molds. And basically at 25% you're sort of okay with glycerin, and at 50% you're for sure okay. But I don't know how many of us mix molds with any of the other low proteolytic enzyme stuff. So we don't, as a rule. But I don't know if anybody else has found that that's a problem, or if you use with the glycerin reactions, if you get too painful an injection site.
Paul, you guys doing much mold shots in general?
You know, there's a sort of a consensus that mold shots really don't work, and there's only certain people that still do them. I don't put molds in anymore. I used to. If there are just like a couple things that patients were allergic to and they're both molds, I say, well, we can try, but I don't know what the data is. But I don't think we'll ever have a standardized mold extract, to tell you the truth. I don't think that's going to happen. And I just have fallen away from it, but that's my personal preference. I'm not sure I have any good data. Does anybody else do mold desensitization?
Very rarely. Fortunately, most of our Northwest natives are negative to mold, so it doesn't come up that much.
Exactly.
Frank, you guys, any of you do molds?
They're very minimal.
Okay.
Very minimal.
So there's one extract that you can mix with molds if you want to, and that's short ragweed, because it doesn't get destroyed by the other stuff. So if you're trying to put it all together in one bottle, you can put short ragweed in with the molds. Except we don't really have much ragweed, so it's not helpful.
They said cat could be mixed as well.
Cat's better than most, but cat's still not stable. Like ragweed's just not digestible at all by these mold extracts. Cat can be damaged. They consider the cats, dogs, pollens, and mites to be low proteolytic activity, but not necessarily stable to proteolysis from other things. The only one that they recommend mixing in that would be ragweed, because it doesn't have any breakdown at all. Now, when you have your allergy immunotherapy orders, the nurses are going to put this together, and they want on the bottles the patient identification number, and they want us to put a picture on the bottle, which I thought that was sort of interesting. Maybe. The name of the preparer, the day you prepared it, the name, the concentration, and the volume for each allergen, the type and volume of diluents, and again, some may be aqueous, some may be glycerin, some may be other alum precipitated. They're all mixed together. And then they want the stock allergen manufacturer and lot number on every one, and the expiration date of the extract. And I don't know that we can put that on the label, so that label would be like a phone book. So I think you have to have some way of putting it together like a package insert, but I asked our nurses, they can't put all this on a label, so unless you have bigger labels than we do, I don't think we can comply with those requests. So then you want to know what allergens and the appropriate dosing. So there's interactions that we can take advantage of in cross-reactivities, like with the grasses. You don't need to do more than one grass. You can just use the standardized grass. And when you're trying to put a bunch of stuff in one bottle, it's really nice if you know what cross-reacts, so you don't have to put as many things in. And they recommend that you do not put stinging insect allergens in with arrow allergens, and I don't know anybody ever did that, so that seemed sort of pretty straightforward to me. And then I guess there's some people who still pull up the extracts in one syringe. They'll pull a half cc out of one bottle and a half cc out of another and inject 1 cc into the patient, and they recommend that you never do that either. And then immunotherapy to foods, there's quite a bit of discussion about it, but they just say it's too dangerous, and they recommend that we don't do it at all. And I'm not sure when that will change. So now, when you start writing up the orders, what you want to know is what you can mix together safely without degrading any components. So short ragweed, you can mix with molds if you ever do molds. Cockroach is becoming more and more of a concern that I think we all have to address now, since the vector has taken it everywhere. And cockroach is a pretty highly protease active allergen, so you want to be careful what you mix with cockroach. So again, that's where you may want to mix your ragweed and cockroach together. And dust mites, pollen, and animals, they don't seem to be any issues when you mix them together. And then immunotherapy for fungus, mold, and cockroach. If you're going to include them at all, they recommend you put all them together, because then if they work, great, and if they don't work, they just digested each other, so it's not so important as the other allergens. Then you want to make a priority of importance for each of the allergens in a specific patient, because when you start going down the list and you get 10, 12, 14 things that you want to put together, when you look at the recommended doses now for successful immunotherapy, I mean, you can fill up an entire bottle with cat. So full dose cat immunotherapy is 4 cc's out of 5 if you're going to mix a treatment set. So, I mean, you have to understand that the more things you can not put in, the more flexibility you're going to have. So the grasses are really good because we just have to put in a small amount because it's such a good extract. Trees, we're not doing too much with combining trees anymore. The extracts are still all independent. They're all temperature sensitive, so you have to store them between 4 and 8 degrees centigrade. And if you get up to 25 or 30 degrees, their potency drops relatively quickly. And then glycerin is basically the best stabilizer. So at 50% glycerin, you stabilize the molds, the cockroaches, the pollens, the pets, animals. Everything is really well stabilized, but 50% glycerin is pretty tough in shots. The people don't like that, and it evidently hurts quite badly. So now, how much do you put in is, I guess, the question that we've all been asking ourselves for the last 30 years. What's the most effective range for allergy shots? And for the standardized allergens, they've got maintenance dose ranges that have been published, and they've been repeated multiple times. The unfortunate thing is that maybe a range over four times one dose to another. So you're going to have to decide how much of each one you want to put in. And successful immunotherapy seems to be associated with achieving a certain maintenance dose for each of the standardized extracts. So if we don't reach that, we're probably not going to be successful. So if you look at these, and this is some data from Hollister, if you look at the recommended doses for short ragweed, 2011, it was 6 to 12 micrograms of AMA, and now in 2013 they recommend 15 to 20. So when you get the extracts, obviously the higher the concentration of the extract, the more you're going to be able to put things together as opposed to filling up one volume. Cat, 1,000 to 4,000 BAUs, and the extract comes as 1,000 BAUs is how most of it's standardized. That means 4 cc's out of a 5 cc bottle ends up being cat. Dust mites, 500 to 2,000 hasn't changed. Grasses haven't changed. Bermuda grass hasn't changed. The pollen that's not standardized, they're still recommending a half, and then you titrate if you're going to use fungus. And now that we have dog extract that's actually reasonably good, the micrograms of KNF1 hasn't changed from 2011 to 2013. And then fire ant, I don't know if any of you are including that yet in your extracts, but that has been worked out as well, but it's not a standardized extract. So you have different strengths with the extract. So some come in you have 10,000 units per mil for grass, you have 100,000 units per mil for grass. With mites, you have 30,000 and 10,000. So you can sort of use that when you're formulating your extracts to make sure you get the right allergen concentration in your final product without going over the 5 milliliter volume. And I find that I go over the 5 milliliter volume a lot. So I'm trying to put everything in one shot, and I had to rethink what amounts I put in. The glycerin is the effective maintenance dose. You want to know the glycerin concentration, because if your patients are uncomfortable every time they get a shot, they're not going to want to do it whether it's glycerin or extract. And 50% glycerin is too much for a shot, but it's not too much to preserve your extracts. So you can figure out what extract concentrations you want based on the percentage of glycerin in the final product or the concentration of allergen. So this is an example of meeting the required amounts for theoretically successful desensitization, and how if you mix all these things together, your glycerin concentration sort of changes as you mix things. So when you look at the trees at the top, none of them are standardized. So they're all recommended in 0.5 mLs because that's the recommendation for all the non-standardized pollens. Lamb's quarter is half the concentration, so the recommendation there for maximum dose is twice as much. Ragweed is standardized, so you can put that in as much as you want. Grass is the easy one because you don't have to put much in. So if you look at the total allergen volume versus the concentration of, here's Drew's mouse problem, you can get up to 20% glycerin, and this is recommended to keep this as stable as possible throughout the year. If you have less glycerin than 20%, then you run the risk that the allergens are going to start degrading themselves. So if you're interested in maintaining potency, getting to 20% glycerin is your key. And if you're interested in putting as much allergen in that may not be, that's what you're going to do. So you need to basically maximize the doses of most of the important components for each extract. And unfortunately, there's equal numbers of articles about immunotherapy where people like, it's definitely physician preference at this point, because I don't think there's any real official recommendation other than they recommend that you don't include less than the predicted minimum and you don't include more than the predicted maximum. And then everything in between seems to be doctor dependent. This new AP dog from Hollister Steer is potentially 35 times stronger than any of the dog extract we've had before. They've had trouble getting it to market, but now it's available. And Hal Nelson just came out with an article about how to add dog into your current extracts. And they recommend starting the dog as its own extract and building up the full dose and then including it. And that seemed to me to be a lot of money and a lot of time that I'm not sure I was willing to commit. So the four of us decided that we're going to retest our patients with the new dog extract and see how positive they really are to that. And then if they're really super positive, we may think about this. And if they're not, we'll just put a couple of extra steps in our rebuild to protect them from this new dog extract. But it's finally, we have one that actually works, which is nice. It's just how we're going to include that in our immunotherapy is still a point of contention. So now if you're going to look at the volume of your allergens as a way to figure out how to make your extracts up, you can look again at the concentrate comes, they have different concentrations again. So you're trying to get the maximum concentration recommendation in the guidelines. So if you're going to do that, you want to focus on this maximum column over here. And then you have to get the maximum amount of cat in an extract. You have 4 milliliters out of 5. So that basically means you have 1 shot for just cat. And if you do dust mites, you can mix dust mites pretty much with everything else because the other extracts are considerably stronger. But if you're going to try and give maximum extract for cat, that's going to be hard unless you're willing to commit an entire vial basically to cat. So that was the only reason to discuss it that one. Now, so you want to write these prescriptions so they're written based on the volume of each individual allergen with respect to the total volume. The more potent the extract, the less volume it will require, so you can add more allergens. If you use the 2011 recommended guidelines for maintenance doses, the volume for each allergen is going to vary based on the concentration. And again, I think that the recommendation is you try and get to the maximum dose, but there is a minimum dose for each of these. I think that's for effectiveness and versus maximal effectiveness. And the current recommendations for adding the dog, again, are that you start it as a single agent and then you go from there. So if you look at extract percentages as a percentage of the total volume, you're trying to get in, again, you want the maximum benefit. So if you use short ragweed, your maximum percent volume would be 12% of an extract if you're doing 5 cc volumes again. And then you can figure it out based on that. And there's 2 or 3 different formulas to figure out how much to use. So you have a glycerin formula, you have an allergy unit formula, and you have a volume percent formula. So cat, again, would go to 80% if you want full dose cat. Dust mites, if you use the good extract, is 13%. Pasture grasses would be 8%. So 1 vial would be cat, dust mites, and grass. And that would be 1 entire 5 cc vial. So again, you're looking at having to either add more shots, more different vials, or maybe not include some things that you would have included previously. So how long are these expiration dates on these things? And this comes back to Gary's comment, is we've never had an infection from an allergy shot. So the expiration dates obviously don't pertain to infection, it pertains to stability. So the higher the concentration, the more stable the products are. So if you look at the weight to volume concentration, a 1-year stability for 1 to 10 to 1 to 5,000, and then if you're at 1 to 50,000 weight to volume, it's only 3 to 6 months. If you look at the PNU categorization, 20,000 to 1,000 is good for a year. Under 1,000 is 3 to 6 months. If you look at allergen units, it's for the 500 or higher, it's 1 year. For less than 500, it's 3 to 6 months. And if you look at the bioequivalent allergy units, 1,000 or greater is a year, and less than 1,000 is 3 to 6 months. And then if you look at the venoms, once you dilute it, the 100 microgram per mil is supposedly only good for 6 months, and then the dilutions are for 1 month. So if you're going to run right out and write all your allergy immunotherapy orders right now and change everything to comply, you have to have the training and attention to detail. And the courses, there's courses available all through the year from the academy and from the college. I was unaware that they actually offer special classes in immunotherapy, not just at the meetings, but you can go to courses throughout the year. And you have to remember that errors in these doses can cause life-threatening allergic reactions. So when you're sitting there tired at night, you're just trying to fill out that last form, maybe you don't want to do that for your allergy shot extracts. And the recommendation from the powers that be is that the maximum doses of allergens in the extracts have been defined, and we should use them and not go higher than the recommended maximum doses. And then the last thing, there was 2 articles that were interesting. The clinical staff preparing your allergy shots should feel comfortable questioning dumb things that we write. And I hope that your staff is comfortable questioning dumb things, because it sounds like that's a bigger problem than I would have thought. And my staff will very commonly come in and say, did you mean to put 0.5 or 5 in this extract? And, it could make a big difference. So you don't want to yell at your staff for saving your butt. And then there's a bunch of references. The most important one is the parameter from the Academy, the 3rd update in 2011. And neither Ashley or Steve are here today. They both worked on that. So I talked to them, but they didn't have anything new from the parameters to suggest. Then this 797 nightmare, if anybody wants to read that literature, I actually have a copy of that result. And then Hal Nelson is the one that sort of weighed in on the dog extract. And then there's some other references here that just reference how this has all come together. And the guys from Hollister and Greer were very helpful providing me information on this. The unfortunate thing is that I mostly got copyright protected documents and I couldn't get in without a password. So I was able to read them, but I couldn't steal any of the slides, which is unfortunate. I could never get the password. So I don't know if that clears up any of your concerns about allergy shots or not, but that's what we know today. Matt.
We had a question from the outside. Who's responsible for inspecting labs where this is all being mixed and so forth? Is it OSHA, or who comes around? And
that's actually a good question, and if you do it in your office, no one will inspect you, basically. If you're a hospital, it's done through JCAH. They'll come and inspect your lab just like any other lab. So, but as an independent practitioner, you don't have anybody who's going to come inspect you unless there's a complaint lodged against you.
Unless you do things like rapid streps or other things, then the state will come out and inspect your lab, and you have to do quality assurance stuff.
And then a somewhat related question: does anybody employ a pharmacist or the like to review IT orders?
You mean after we write them?
Yeah.
I don't. That wasn't brought up in much of the literature on the Academy committee when they do the revisions. There's pharmacists that review all that data, but I don't know about reviewing immunotherapy. I'm just curious, how much have you had any real formal training in immunotherapy? It's sort of like the part of allergy that we never talk about. All of us do it. My formal training was very, very minimal, so I just sort of picked it up as I went along. But I think that's something that we really don't get a lot of training in. So I just didn't know if anybody else had more training than me, because mine sure was minimal.
At 2 hours.
2 hours? How about here in the program? David, Matt, do you guys get any training in that?
Yeah, we sit down. It's reasonable. Frank sits down with us and we go through.
Do you have one session with Frank? That's all you get about it?
Well, and then they spend also some time in our lab, seeing mixing, pollen collection, which is a special thing, but then also with the nurses doing first shot teaching. That sort of thing.
And we go through our orders too, because we had to switch over to the pharmacy making them up. Right. So we had to tailor all that with regard to the different concentrations and making this.
I was really surprised that all of the liability results in us. I mean, if we write the order and the nurses screw it up, it's our problem. It's not their problem.
For everything.
Well, yeah, but this is very specifically our problem. I mean, it's put out there. They're not liable for anything. We're liable for everything that they do, which I thought they would have some culpability in that case, but obviously not. So it's not regulated very strongly, and no one will inspect your office unless you're a medical facility that's got government grants and things, I think, is what you'd be expected.
JACO has an outpatient branch that inspects outpatient facilities and clinics.
think they come around, don't they? Joint Commission?
No.
No.
You gotta be a hospital.
No, you have to be a hospital.
Well, it was just really nice that they forced the Academy forced the U.S. Pharmacopoeia group to reevaluate allergy shots from sterile compounding, or we would have been in deep trouble. So that was a battle that they fought behind the lines for us to allow us to do this. I could just see bottles coming from the mixed from the manufacturers in these little 1 milliliter bottles that we have to use, like with B12 now. You can't get multi-dose B12 vials because of this 797 law. And if we had done that with allergy shots, it just would have added a whole new level of complexity that would have made our lives crazy. So I'm just glad that they were able to work that out. But as Gary said, there's never been an infection from immunotherapy, which is remarkable in and of itself.
Well, it's skin testing too. Here, that's even messier and dirtier. I've never heard of anybody having infections at the site of skin testing. I'm sure it must have had. You've had one? You must have sneezed on it.
So if you only want to read one thing, if you read the Academy and the third revision guidelines, it has more than you ever want to know about immunotherapy in there. It's about 50 pages of pretty intense reading and about 8,000 references at the end of it. But that may be the only training that you get, and that may be the best thing to do is just read the Academy guidelines. And it's been redone 3 times in the last 8 years, so it must be something that's on the burner. And you weren't involved in that, Frank. That was just Steve and Ashley.
I have a question.
I'm just curious if folks are doing much cluster or rush immunotherapy. I've dabbled a little bit in rush.
Well, the rush immunotherapy used to actually get paid by the insurance companies. They'd let us put people in the hospital and do it all in 2 days. And I only done that for bees. I've never really done it for anything else, so I don't know the answer to your question. But what we found in our clinic, and I don't know, you might have a different situation, is we can only get paid for 1 shot per day. So if we give them 6 shots, we eat the cost of the numbers 2 through 6. So Regents and Premier in our clinic won't pay for more than 1 injection per day. Now, maybe 2 shots at that one time.
This
So
may be an error, but there's a rapid desensitization code that can be used, and it's by the hour. And so we've been paid on that, actually, and it works out fairly well. So you might look
I'd
into
like
that.
to know what that code is, because we were never successful being able to bill, but we billed it as a regular allergy shot, and maybe that's why.
And Art's kind of the go-to guy. He might be listening right now.
Take a cut.
Where's our?
There's a lot of pre-medication involved. And I've had success 2 or 3 times so far.
The burning beat off.
Makes sense. Mike?
Well, I recall in terms of reducing local reactions now, an antihistamine and an anti-leukotriene is pretty common now. But back in the old days, I remember somebody used to take the syringe and draw up epinephrine and squirt it back into the bottle and use that epinephrine-coated syringe to drop the antigen. Has anyone ever heard of that?
Ironically, a practice in California where 2 of our former fellows are still does that, because I got a transfer patient. I'm not, this predates them, but it says right on there, wash syringe with epi before drying up. And they also have a separate thing for washing it with diphenhydramine.
Have you ever heard of that, Paul?
No, that wasn't discussed. That wasn't discussed in the Academy guidelines.
We're not going to sign it.
We didn't have that.
Yeah.
So I'm sure if we went around the room and we all said what we do, we're probably all doing it a little different, because there's not really any obvious protocol to follow other than aseptic technique. That seems to be the only thing people
How
agree
about
with.
always injecting in the arm so you could put a tourniquet in them on? Does anyone ever use a tourniquet to a shot reaction anymore?
We do.
No, I don't.
We put a tourniquet in and give them epinephrine right away.
Put a tourniquet.
No,
Our nurses don't do that.
they should.
Well, they should.
Do you have your nurses aspirate for blood?
I thought
Yeah,
so.
yeah.
I thought so too, but there's a campaign to just eliminate that altogether. And when you use a 27 or a 29 gauge needle, I don't know what you're going to stick that's going to be much of a concern.
Right.
And that's why they say not. But they say if you get any blood, you're supposed to throw out that syringe and throw out all the extract and give them another shot. So I thought that was an interesting thought too. But I don't know that when I give allergy shots when my nurses aren't there, I aspirate a little, but I don't really try very hard. I pretty much just inject them. But, so, anybody around here had a death from immunotherapy ever? Anybody local?
Had full-blown anaphylaxis 2 times in 30-something years. Yeah, hospital. Hospitalized. That's in 30 years.
So no deaths. And you
No, and interesting, the one, I saw the nurse give the shot, and she pulled back, and there was a little blood on the syringes. The nurse had been giving shots 30 years, too, and it was instantaneous. The guy just said, oh, I'm feeling strange. And we carried him right to the exam room and gave him epi within probably 30 seconds. Took a couple of shots. Make a long story short, he just puffed up, his face was just swollen. We were just kind of slapping around. Paramedics came. By that time, he was starting to come around. He never totally lost consciousness. Went to the emergency room. He came back about 3 or 4 hours later. His face all swollen. He said, when's my next shot? We all went and beat him to a pulp. He said, we had post-traumatic stress disorder after that. So we're never giving you another shot.
people are determined. There's